So this is about the residual cancer burden, the RCB scores after giving neoadjuvant chemotherapy, and how is the association with the long-term survival outcomes. So this was a 5,000 patient pooled analysis. Next slide. Okay, sure. I'll do it. So we already have data from the collaborative trialist neoadjuvant breast cancer, which included almost 12,000 patients. And there was found to have a strong association between the pathological CR and the long-term survivals, especially in the TNBC group and in the HER2 positive who has received trastuzumab. But this looked only as a binary outcome of a patient with residual disease versus a complete responders, and it didn't provide a distinction on the various levels of residual disease present after the neoadjuvant therapy. So the residual cancer burden, it provides a continuous scoring, and it has been validated in few smaller studies. So the one I'm going to discuss is a pooled analysis which to evaluate the overall association between the RCB and the long-term outcomes, and emphasis on the each subtype of breast cancer. So this included 5,000 patient population who were treated with neoadjuvant systemic therapy for almost 25 years. So the primary endpoint was event-free survival, and the secondary outcome was the distant relapse-free survival. It included cohorts mainly from the US and the UK. And out of the 12 cohorts, 5 were actually prospectively scored for the residual cancer burden, and the remaining was done retrospectively. So the subgrouping is the conventional triple negatives and the HER2 positive with the ER positive or negative, and all the 3 positive. So the majority were HER2 hormone receptors positive and followed by the triple negative. The scoring for the RCB was normally divided into 4 classes. So score of 0 corresponded to a pathological complete response, and score 1, 2, 3 with 3 score class matching with the majority of the patients with the maximum residual disease. So the analysis looked into the association between the RCB score and the survival, was assessed in the mixed effects Cox model, and Kaplan-Meier was used for the survival analysis truncated at 12 years. So the results were, if the increase in the RCB scores was significantly associated with the worst event-free survival, you can see in the graph. So it was even in all the overall population, it was almost a near linear increase in the relative hazard ratio is there in all the groups, especially when we come to the increase in the hazard ratio with each unit increase in the RCB score. The maximum event-free survival, the hazard was maximum for those with the HER2 negative group, and those with the hormone positive had up to 1.5 hazard. And so those with the scoring of class 2 or 3, they definitely had a distinct outcomes compared to those with the complete responders. So this graph shows the RCB scoring with the event-free survival for a triple negative breast cancer subtype. So which clearly shows there is a demarcation in all compared to 0 to 3. And the next curve is for the HER2 positive subtype. Even in this, there is a clear demarcation in all the classes of the RCB scoring. This curve actually shows that in those with the HER2 hormone receptor positive, the curves actually diverged beyond 10 years. And the next curve, those with only hormone receptor positive with a HER2 negative, even beyond 10 years, the class of 0 and 1, they didn't really make much difference. So given the increasing options of escalation and de-escalation of the adjuvant therapy in the setting of residual disease, prospective evaluation of the RCB as a standard pathological reporting should be warranted. And especially at least for those with high risk of residual disease and worst outcomes. The strengths, it is the largest data which we have, and this is also based upon the subtype specific prognostication of the RCB scoring. It might help in decision making in the adjuvant setting for escalation of systemic therapy, but the limitations was, it was from 94 to 2019, so there is a lot of discrepancy in the methods used to assess the ERPR status, and the regimens were varying, the duration of treatment, the extent of the metastatic workup done at the baseline, and there was also use of investigational drugs in few cohorts, and out of 5 studies were done in a retrospective way. take home, this might help in deciding the dose escalation. But the thing is, how much to escalate for each class of RCB, we don't have an answer. Whether it is the intensification of therapy or the duration of treatment, we don't know. And the next study, it is the outcomes following sentinel lymph node biopsy compared to targeted axillary dissection in patients who had a clinically node positive disease to begin with and who has become a node negative following a neoadjuvant therapy. So this is also a retrospective analysis. Already we have a background information that in patients with clinically node positive disease, the rate of false negative rates of following a sentinel lymph node biopsy is more than 10%. Using a dual tracer mapping or removal of more than 3 sentinel lymph nodes or combining with a sampled clip lymph node dissection, that is called as a targeted axillary dissection. This will help to reduce the false negative rates. So we are just going to look with the help of this study whether the recurrence rate was...
I'm sorry, you'll have to wind up because you have finished your time. So please come to the last slide.
Sure. So this is basically comparing the sentinel lymph node versus a targeted axillary dissection, which was done using a clip was placed before chemotherapy and the nodes were specifically removed. The number of nodes removed didn't differ much between the sentinel lymph node or a targeted. And comparing the axillary recurrence or a locoregional recurrence or any form of invasive recurrence, it didn't really much differ. The take home is like, so it helps to increase the sensitivity of removing the sentinel lymph node dissection when a targeted axillary dissection is done. But it didn't differ in a much volume because only one node extra was removed in the sentinel lymph node. So this appears to maybe increase the sensitivity, but the involvement of expertise and the cost efficacy has to be seen. And did it really make a difference in the outcomes of lymphedema or in the survival outcomes has to be evaluated prospectively. Thank you.